Okay, so this is our transplant financial basics for dialysis social workers. We try to do this at least once a year for you guys. Okay, you should, hang on one second for me because my camera cut off. I don't know why. Okay, so let me introduce my colleagues real quick. Lakaya is down at my bottom here, and Jeanette Davenport is above. We are the Kidney Peng team here at Mayo Clinic right now. I did put a copy of the presentation out in the chat, so you should be able to get that. Please hold your questions until put your questions out in the chat and we'll address them at the end. Okay, you can either put them in the chat or the Q&A. We don't care which. Okay, so we're just going to get started here. All right. So we want to let you know that this process that we've developed here at Mayo Clinic has been going on for about 7 or 8 years. It was developed years ago, and then we refine it every single year based on our experiences and what our patient feedback is. Okay, and we really do work very hard here to prepare our patients for this journey and what lies ahead of them. Okay. So the learning objectives here are to understand why budgeting for transplant is critical, to understand the basic types of insurance and how that impacts financial planning for the kidney transplant, and to understand some of the socioeconomic factors and barriers for our patients, and to understand the system that we have here at Mayo to help the patients with their goal setting and then through the process. Our follow-up and monitoring process. Okay. So why budget at all? What's the point? These patients have lifelong medication costs. They also have lifelong medical costs, insurance costs in an ever-changing insurance environment. They may have loss of income for both the patients and or the caregiver, and they can have relocation costs. Here at Mayo, we require that they relocate here if they live further away than an hour from our center. There are also some special issues with the kidney patients. You guys very well know that they get their benefits sooner, but they also lose their benefits sooner. So 1 year post-transplant, their Social Security disability is reviewed, and many people lose their disability coverage and their disability income at that time. Their Medicare usually terminates 3 years post-transplant if they're only eligible due to end-stage renal disease. And then you know about the Immuno bill that passed in 2020 that extends the Part B coverage. That is only good if there is no other options for coverage. There is a CMS Medicare coverage of kidney dialysis and kidney transplant booklet that's available through CMS. And Section 3 covers the transplant coverage for Medicare. Now, AKF, you guys are very familiar with this too. It ends after transplant. It usually ends at the end of the insurance calendar year. So if the patient's transplanted in June and they're on Medicare and you're paying their Part B premiums, that coverage is usually going to end at the end of December. If they are transplanted in the end at the last quarter of the year, this was a change, I think 2 years ago, they can be extended for another year, but it's not guaranteed. We also have a dwindling and a changing resource environment. Patient assistance programs come and go. They're funded 1 week, they're not funded the next week. So we're cautious of all of that. So I'm going to turn it over to Lakaya now, who's going to talk about some of the insurance basics.
Okay, insurance basics. So you have primary plans. That's the plan that pays out first. Secondary pays out second, of course, and tertiary that pays out third. Supplemental or gap coverage, those are extra insurance that can be purchased to help pay services and out-of-pocket expenses that are not covered by primary or secondary insurance. Right, types of insurance, you have commercial plans, marketplace plans, Medicare, Medicaid, long-term care, and critical illness plans. These are supplemental plans that can be purchased to offset some of those medical costs. After a critical or catastrophic illness is diagnosed, you get a lump sum payment or a monthly payment depending on the coverage. Commercial plans, private, employer, COBRA, spouse's employer, parental coverage, retirement, or military, those TRICARE plans. Marketplace plans, those can be found through healthcare.gov. You can get coverage if other coverage is lost or after a life-changing event. This becomes inactive if a patient obtains Medicare. The rules are ever changing due to political environment and other factors with those plans. All right, the 4 parts of Medicare: A, which is hospital insurance; B is medical insurance; C is those Medicare Advantage plans, which combines A, B, and Part D; and then D is prescription drug coverage. Medicare Advantage plans, those include A, B, and Part D. The benefits of some of those plans, they usually have a lower premium. One card is covered for all services, and they may include some dental and vision. Some of those do include relocation benefits, which is really beneficial to patients who come to Mayo, because remember, there is that 30-day relocation period for patients who are more than an hour away. Some of the limitations of those plans, they can't be purchased supplemental coverage, and they may have in and out of network plans. I do want to point out that Mayo has made some changes, and there are some of those Medicare Advantage plans that we do not accept. So I do encourage you to always reach out to our transplant financial coordinators to see what plans we are accepting at the time before referring a patient. Medicaid, there's full community Medicaid, QMB that pays for Medicare premiums, copays, and deductibles, Slim B, and QI1, I want to say, got it. That only pays Medicare Part B premiums. There's also the medically needy share of costs, and that becomes full community Medicaid when the share of costs, the out-of-pocket, is met for the year. All right, secondary insurance coverage. Secondary can be Medicare, it can be commercial, usually employer or pension plans, and Medicaid. It cannot be a marketplace plan. Secondary coverage pays after the primary coverage according to each plan's rules. Coordination of benefits period. This explains how plans coordinate coverage for patients with Medicare. Which insurance plan has the primary payment responsibility and the extent to which the other plan will contribute after the primary. For ESRD patients, there is a 30-month continuation of benefits period, and then Medicare automatically becomes the primary. Supplemental or gap insurance, these help some costs that original Medicare does not coverage, such as co-payments, co-insurance, and deductibles. They can't be purchased if a patient has a Medicare Advantage plans. They are usually much cheaper for patients who are over the age of 65. All right, and this is just a chart we included about Medicare gap standardized plans. This is effective for January 2023. The Medicare Part D donut hole. Most of our patients here, we're seeing they no longer fall into the donut hole for their transplant needs. Those that do are usually already experiencing the donut hole due to the insulin costs. We no longer budget a separate line item for the donut hole. Right, low income subsidy or extra help. This helps with Medicare Part D, the drug costs, and the Medicare D premium. This is automatic with full Medicaid, QMB, Slim B, or QI1. It is not always 100%. Next year, there will be no partial. According to my understanding, it will all go to full Medicaid. These are the Florida income limits for 2023. These change annually. For the individual this year, it was $1,843, and for couples, it was $2,485. In 2022, new coding allowed for extra help to apply for MUNOs. This has continued into 2023, except for the United Healthcare MAP plans. always encourage your patients to apply for low-income subsidy extra help. It's a really simple application. Please encourage them or assist if you can.
Okay. I'm going to come back on and talk about kind of the types of information that's given and who's giving it, who's given what information. So here at Mayo, the transplant financial coordinators generally review the insurance and the patient's cost for the evaluation appointments and testing, the hospitalization, the clinic follow-up costs, and any relocation benefits that the patient has under their insurance. The transplant social workers concentrate on the medication costs, the relocation costs, any loss of income, caregiver or patient, and insurance premium cost. So at other centers, this can vary a lot between the different transplant centers. At some centers, the financial coordinators might provide all of this information. At some, the social workers might be providing all of it. And some centers just tell you to go and talk to the insurance case manager to get your information about these costs. So it varies greatly between centers. So Jeanette's going to come on now and talk about how we develop a budget and a fundraising goal.
Okay, so our social work evaluation here at Mayo is pretty thorough. Usually takes about 90 minutes, in fact, and we get pretty in-depth with patients to assess for those psychosocial factors that we know impact transplant outcomes. Some of those things we're looking for include poor social support, financial issues, mental health issues, dysfunctional personality traits and disorders, poor adherence with medical or mental health follow-up, alcohol, substance abuse, and smoking, and inability or unwillingness to understand those risks and follow up follow-up that is required for transplant success. We're also going to review the patient's income, their expenses for the household, their insurance, and of course, what resources they have available to them. So we're going to ask patients to provide what their monthly income is for the household, and we're going to look at what their discretionary income might be. Of course, many patients are not aware offhand of what that discretionary income might be. So if that's the case for them, we can help them to identify that number for them by reviewing all of the details of their monthly expenses and compare that to their income, of course, and help them calculate a figure for that. We're also going to ask them about funds available to them through savings, checking accounts, things like that. Okay, so there are available resources. We look at savings, investments, 401k, 403b accounts. If a patient is planning to utilize funds from a retirement account, such as a 401k for their transplant-related expenses, we always verify that they are in fact able to withdraw those funds and that they understand what those penalties, taxes, or interest might be that they'd be responsible for. We also look at letters of support and any funds they may have already raised through something like a GoFundMe. Okay, so this is the chart that we create with our patients during our assessment. The patients who see us in person will take this home with them so that there is no mystery for them as far as what those expenses are going to be. And then if they do have a fundraising goal, it'll be detailed for them here and where we got that figure from. Patients who see us virtually will receive this through their patient portal. So in this chart, as you can see, whoops, there we go. On the left-hand side of the screen, we're looking at all of those projected first-year expenses. We're not looking here, if you notice, at any hospital bills or doctor bills that patients may receive. Of course, we know patients will receive those, but we're focusing in on all of those expenses that are critical to the success of the transplant. So we're looking at immunosuppressant copays, preventative medication copays, insurance premiums for those patients who are receiving that AKF funding that Pat mentioned. So those patients are not accustomed to paying insurance premiums for themselves. So we want to prepare them for at least to take that over for at least 6 months of coverage. We also look at relocation, lodging, food, and travel expenses for those patients that live more than an hour away from the Mayo Clinic. And we want to budget for any loss of income that a patient or their caregiver may experience as a result of transplant, particularly if that caregiver lives in the same household as the patient. The right-hand side of that chart, you're going to see that we compare it to, all of those expenses to the resources that a patient has reported, including the discretionary income, savings, retirement accounts. So when we compare the bottom line of those two sides of the chart, that's where we come up with that fundraising goal if the available resources is less than, of course, what those expenses are projected to be. Okay, so on this page, you'll see this is where we would detail for the patient what their fundraising goal number is if they have one. We also let them know that they can still be listed with us here at Mayo for transplant with a fundraising goal, but they do get listed what we call status 7 or inactive, which means that they are not eligible for an organ offer or that living donor transplant surgery until the fundraising goal has been completed, and they provided documentation of that for the social work team. They do continue to accrue wait time. We ask that they start working on fundraising within 90 days of listing, and if they don't make progress by their annual update, there is a risk of being removed from the transplant list. Okay, so this is the immunosuppressant medications that we're looking at here. That was that first category that we looked at on the chart. So here we detail what some of those copays might be for these immunosuppressant medications, depending on the patient's insurance coverage. So you can see the various Medicare plans and the combination, how that coverage looks if they do have a primary, secondary, or a supplement, or if they have a Medicaid product. If they do have a commercial plan for their insurance, we always put to be determined for in that category. We're not able to predict as easily what those copays might be because commercial plans vary so much. So we do ask that all of our patients complete specialty pharmacy registration as a part of their transplant workup. So they will register with one of the specialty pharmacies that we've identified for them. And when they call that pharmacy to complete that process, the pharmacy is usually able to give these patients more of an idea of what their copays and their maximum out of pocket is likely to be. Preventative medications, so these are the ones that patients are taking for a variable amount of time after transplant, usually within the first 6 months. Of course, those immunos are the ones they take forever. But with the preventative medications, again, you'll see here what the copays might be, and definitely notice the difference between with extra help and without extra help, because it is pretty significant for a lot of patients, that cost difference. Again, with the commercial plans, that's to be determined when they complete their specialty pharmacy registration. Okay, this is a list we provide to our patients of those projected post-transplant medications. The top half are those immunosuppressants. Those are the always and forever ones, of course, and the bottom half are those preventative medications that we were talking about. So we provide this as a reference for them. This is the form that I was mentioning earlier with as far as when they complete that specialty pharmacy registration process. So they will complete this for us just over the phone with the representative from that specialty pharmacy. They're going to find out those monthly medication costs, whether or not they have low income subsidy, and of course that maximum out of pocket. They let us know whether or not they're going to have difficulty paying for these medications and return this to us. Okay, so that AKF insurance premium assistance, many of you are, of course, very helpful with your patients in obtaining this grant. They have to have had the grant for at least 3 months prior to transplant to continue. If they did, then they can continue to receive that healthcare insurance premium assistance after transplant through the end of the insurance coverage year. And if the transplant occurs in the last quarter of the year, AKF now considers funding for another year of those premiums. Patients do have to go into the AKF grants management system themselves and update their status as transplanted within the first 3 months. So it's important that they do know how to access that account. And then when we're budgeting for patients who are receiving this assistance, we ask them to budget for at least 6 months of those premiums, just because we never know for sure, of course, when that transplant may occur and when their AKF funding will end. Okay, so this chart gives you an idea of the total months of coverage that a patient will be covered with those insurance premiums, with when they have AKF funding, depending on what month of the year they are transplanted in. So we kind of give them a little breakdown of all that coverage that they could expect. Relocation expenses. So we ask patients to budget for that relocation when of course they do live that greater than an hour away from us. They'll be staying with us for that 30 days here in the Jacksonville area. We ask for that budget to be for lodging, food, and gas, and we estimate that at basically $100 per day. We know this is kind of a low amount depending on where patients stay and what their expenses look like while they're here, but of course, budget hotels, buying groceries, and cooking their own meals can be helpful in impacting that budget for them. There are some resources to assist with hotel costs, but not all patients will qualify for this. Food and gas expenses, we estimate at about $500 for the 30 days. We know that patients can anticipate to be in the hospital for that average length of stay of about 2 to 5 days for kidney transplant, and they'll plan to be in our community for another 3 weeks after that. Other expenses that we look at in budgeting include those transportation costs. So particularly patients who are having to fly here to Jacksonville to get to us for transplant, or if they're planning to rent a car while they're here. Also patients who are planning to hire a private duty caregiver as a part of their transplant recovery, we want to factor in those costs as well. Okay, so this is a summary of some different fundraising organizations. It's a nice little comparison for patients to look at some different options and kind of compare and contrast some of the different organizations that they could use to do that medical fundraising or a GoFundMe account. So many patients are familiar with that GoFundMe, but not the others necessarily.
Okay, so I'm going to come back on now and just kind of walk you through the rest of our process here at Mayo. I know somebody put in the question and answer that the chat isn't working, and I don't know why that is. I'm going to have to figure that out. We will get the presentation to all of you, even if we have to email it to all of you. So don't worry about that. Okay. If a patient meets all criteria after they've met with the whole team and they're approved by all the disciplines, they're going to get through selection committee and they'll be approved and they'll be listed as a status 7, which means that they can't get organ offers until their fundraising goal is met. And generally they will not have living donors worked up. Sometimes we bend that rule a little bit if the fundraising goal is really low. The listing letters usually tell them too that they have to make progress towards their goal within a year, or they're not going to be, their listing isn't going to be continued. When our patients are approved for listing, and we go ahead and we fill out this reminder list, and this is used to manage these patients. So every 90 days, one of our social work assistants calls these patients on the list. So that the reminder list gives a date, and they're followed up with every 90 days. They let us know if the patient has any issues or questions, and if they're not making progress. And then the social worker will call them to follow up with the patient. If they're not making progress by the annual visit, we can request a 45-day letter warning them that they're going to be removed. Patients are required to send us documentations once they have their funds. They're required to send us in something that shows that. When we receive their documentation, we notify the team. The RN coordinator then reviews the chart, sees if any other testing or appointments are needed, and then we will schedule those if they are needed. If they're not needed, they'll just bring them back to selection for a status change from 7 to 1, which is active, and then they start getting organ offers. Our post patients are given a questionnaire to help us to continue this process every time we see them. at their update appointment, which for us is usually every 1 to 2 years, depending on the patient. The fundraising goals reviewed and revised at each appointment. If there's a new fundraising goal, the team is notified and the patient is made status 7. If the patient's insurance or some situation has changed and they no longer need a goal, we'll notify the team that way too, and they can be made status 1. The reminder list is changed immediately after the patient is seen so that the correct goal is communicated at all times to the patient. So the final budget and the fundraising goal. Again, the transplant financial coordinators are providing deductible information, cost sharing or co-insurance info, max out-of-pocket information, and in and out of network benefits. And they're also telling them any donor benefits or donor costs that they could have. So to put it all together, with our way of providing information, the patient really needs to add any costs that the transplant financial coordinator is telling them to anything that we're telling them, okay, to come up with their total costs. So why is it that we don't give one number? I always think this, and I always felt this, and I think we always hear this. And the reason is there's a different focus, and there's just a different focus in who's providing the information and different timing for the bills of those things. So most hospitals, including Mayo, will work with patients on a payment plan for the hospital bills. That will work. They don't have to pay that hospital bill immediately. And patients can always ask for charity assistance from their hospitals if they're struggling to make payments. If you have patients that are struggling to make payments for old hospital bills, please tell them to reach out and talk to the billing office in that hospital to see if anything can be written off. Most states get funding for charity care and will write off some of those balances if they're asked. In our case, most pharmacies, hotels, and grocery stores will not, unfortunately, work with payment plans. They're not going to do that for our patients. So they have to have the resources available for that. Now, the research, like we said, we've been doing this as a research project for a number of years. This is the post-transplant follow-up questionnaire that we give our patients. And it really asked them how well they felt that they were prepared for their expenses. And if they were able to afford their medications and that kind of thing. And we also asked them if they're working and that kind of thing. And we asked them how they reached their fundraising goal too. So this is our internal review board research project that has been going on. The objective of this was to see how ready the patients felt like they were for this process. This has been going on again for 7 or 8 years, and we are likely going to be publishing a paper on this whole process, hopefully sometime in the future. 92% of our patients who fundraise and 92% of the patients who did not fundraise reported that they felt adequately prepared for the cost related to transplant. We think that's a pretty darn good number. I don't know a lot of other transplant centers, and I've worked at other transplant centers who could really say that the patients felt that well prepared. I think we're pretty proud of that. 63% of the fundraising patients were younger than 50 years old. So again, we're seeing those younger patients that really don't have the savings and the retirement funds and that kind of thing that they can tap into. And the number of patients in the study who were employed has decreased by about 11% from their initial evaluation to their 4-month follow-up. So they're not able to continue working a lot of times. So when we started this process, and since then, because we update this every time we look at this, we looked at some studies about what was going on in the transplant world. And in one study, 70% of the transplant programs reported having serious problems with their patients being able to afford their meds. 47% indicated that over 40% of their patients had difficulty affording their immunos. 67% reported deaths and graft losses attributable to the cost of post-transplant meds. Employment and financial status have a strong association to graft and recipient survival. And low compliance is often associated with medication affordability and even the follow-up care affordability. And the immunos are vital, but the cost is an issue, even though the cost has declined pretty consistently. The literature also says that the transplant centers need to be providing their patients with enough information to make informed decisions about whether transplant is the right way for them to go. We need to be letting them know the financial consequences ongoing through their lives for this process. And we're expanding access to transplant care, but it's threatened by the high cost of the care, even though the costs some of the costs continue to go down, like the medications. And we're getting higher risk recipients with more complex medication regimens. So the costs are going up for those patients. So in conclusion, we do feel like financial preparation and budgeting is really critical for transplant. Dialysis and transplant social workers have to understand kind of the basics of insurance and how the insurance choices impact the financial planning for our patients. And we've developed a system to assist our patients with setting financial goals and pretty concrete way of doing that. And we help them follow up on their progress and stay in touch with them. The research indicates that transplant centers have to prepare their patients financially for transplant to avoid bad outcomes. Okay, so we're going to open it up to questions. And while you're doing questions, I'm going to leave this CEU certificate up on the screen here. So Lakeya, do you want to throw out the questions?
Yeah, there's a question. It says, I'm confused about the relocation process. If a patient is working in another state, they will surely lose their job. Just need clarification. I can answer. So with relocation, during our assessment, we discussed this with the patient. What are their plans for the relocation process? There's a 30-day recovery period. This is for Mayo Jacksonville. Each state that Mayo is listed in, they have their own requirements for relocation. So Arizona has their specific requirements, so does Minnesota. For Jacksonville, it's 30 days. During our evaluation, we discuss with patients their plan for time off. Do they have short-term disability, long-term disability? Will this be FMLA unpaid? We discuss all of this during our evaluation. 9 times out of 10, patients always have a plan. They've already discussed it with their employer. If this is going to be a loss of income, we factor that into the fundraising goal for the patient, or if they have appropriate resources they've already set aside to accommodate for that loss of income they would suffer. So we haven't seen a big issue with this because most patients know there will be a recovery period from transplant. You can't get a surgery and go back home. So the next one I saw. Okay. Will we be provided financial planners contact information to see what Medicare Advantage plans are accepted? The financial coordinator.
Okay, I'm going to put their number in the chat. 904-956-3745. And that should go to everybody.
Right.
You
There's
see it?
another. Yeah. Does this information apply to all Mayo clinics? I'm in Nevada. Our patients go to Mayo, Arizona.
I'll take this one.
Go
So there are some different relocation requirements. Usually the medication costs are pretty standardized between the transplant centers. That's more a Medicare and a Medicaid supplement kind of driven thing. So usually the medication costs are the same. I think Arizona requires 4 to 6 week relocation, but they would be able to best tell you that. You can just reach out to one of the social workers there. I do think that they look for the AKF funding to be at least 6 months to 12 months. So it's pretty much the same.
Right. Can you talk more about how Extra Help helps with Part B copays?
Yeah. Hey, Laura. Lara. So we found this out literally, I think the middle of last year or the first quarter of last year, where all of a sudden our patients, when patients had Medicare A and B and just like Slim B Medicaid, they were not getting we were budgeting for them to have their 20% copays for the Medicare Part B immuno cost, for the balance of the immuno cost. We found out in that first quarter that Slim B that was coming with the Extra Help, and that the Extra Help was then applying to the 20% of their immuno cost, which is a beautiful thing. That was a new thing. We've seen that continuing this year with everybody except United Healthcare and with their Medicare Advantage plans. And we are complaining to the states, we're complaining to Medicare, we're complaining to United. So we're not getting anywhere with that. But everybody else, we have not had a problem with any other insurance and getting that 20% covered when they have the Extra Help with the Medicare costs, with the prescription costs. So that's been an unusual thing, but it's a good thing for our patients. It really helps save a lot of money.
Right. I would like to know what is considered adequate insurance coverage for transplant. Some transplant centers want patients to have Medicare and Medicaid or supplemental insurance plan. What is the standard insurance coverage for transplant?
You know, we don't require that they have any specific insurance, other than it has to be an insurance that we accept here. So Medicare is accepted here and some Medicare Advantage plans. To get to the initial eval, you do not have to have anything other than those, either one or the other of those coverages. When they meet with us, if they don't have the supplement and that kind of thing, we're going to talk about how much their medication costs are going to increase from that, how much their relocation is going to be. So they can come in here with just having Medicare A, B, and D and get through our process, and they'll have a fundraising goal, but sometimes they can meet that and that's all they want. So we don't have that here at Mayo. Some other centers may have it.
Pat, Karen has her hand raised. I'm not sure how to unmute her. She's at the top.
I'm telling you, every time we use Zoom has changed something.
Yeah.
So, okay, Karen, you should be able to talk.
I apologize. I didn't have my hand raised. I must have hit something when I was looking at the Q&A. I apologize.
Okay. Okay. All right.
Okay, let me see. I got a few more questions coming in. What about Kaiser? How do they work with Mayo?
Kaiser is working much more now, I think, with Arizona and Rochester than they're working with Jacksonville. They used to come here for the liver program, and we're not getting as many of them now. And I think just because the relocation costs are cheaper for them to go to Arizona, and Arizona has pretty much high volumes. But Kaiser is fine too. Kaiser can come here. Right now, though, I think most of them are going to Arizona.
Pat, there are a few people who are having issues with the CEU, the link.
Okay. What are they scanning the code or putting in the?
One of the persons said they scanned the code and used the bit link and still having an issue.
Okay, hang on. I'm going to try and scan the code. Okay, so it's working for me. What I would suggest is maybe screenshot that and try it again once you're off the webinar. Maybe it's just giving you a problem because you're still on the webinar.
All right. Can you provide a list of Medicare Advantage plans and EGHP that are accepted?
We cannot. You would have to reach out to the financial coordinators, and I think they're now trying to keep a list online somewhere. So reach out, use that phone number that I gave and reach out to them and just ask them if you can have a list of the current plans or a link to where they're keeping those.
Right. How many patients with EMA, emergency medical assistant, are accepted for transplant on an annual basis at Mayo Clinic? I know the number of patients accepted are limited.
So the interesting thing here at Mayo, Mayo is actually not a Florida Medicaid provider. So for kidney, we don't take any patients who are Medicaid only. I think those patients, I think they're mostly heart patients that we do accept. Might be some livers too. But there are no kidney patients that are only accepted here with just Medicaid.
Right. I have a patient in Kansas whose insurance requires a transplant at Mayo Clinic. Does the patient need to call to schedule a pre-transplant evaluation? Will they receive all this information at that time?
Okay, so many of you probably know that we have the contract with Walmart. So this is likely a Walmart patient or a Sam's Club patient. What happens with them is you just go ahead and send the referral in. We will reach out to the insurance and let them know that we've received a referral. Once that happens, HealthScope gets involved, and HealthScope actually makes all of the arrangements for them to come here. They work with our team to get all the flight arrangements, all the hotel arrangements. We wish we had that with every patient. And who would have thought? Walmart.
I know, right? All right. They're asking for the financial coordinator's number again. Can you repeat it, Pat?
Yes, it's 904-956-3745.
Right.
Oh, and somebody put the link out there. I don't know who our
Yes.
anonymous attendee is. They must work here at Mayo. But we appreciate them.
Thank you.
Yeah. Okay, good. Thank you. Thank you. Thank you.
Can we receive the document via email?
Yes.
I think that's the PowerPoint.
And I think what I'm going to do is I'm just going to go out and pull a list from the evaluations that you complete, and I'll send out or from the Zoom attendees, and I'll send it out to you guys because it's good to have. It's like a nice little thing. So I will send it out to you guys either today or tomorrow. Okay.
Right. Hello, I have a patient in Puerto Rico that shows interest in being evaluated there. What insurance is accepted for these patients?
The same insurance that is accepted for everybody else.
Yeah.
So, and we have a lot of Puerto Rican patients here. We get a lot of patients from Puerto Rico. Send them. Just contact just send the referral or contact the transplant financial coordinators to see if we accept whatever insurance they have. But we do generally accept their insurance.
Yeah, we do. Great presentation. Thank you.
Good. We try to do this. We're going to actually try to put this out, I think, on our Mayo YouTube channel so that you guys can get at it when you want to get at it. So we're trying that. We're going to see if that works and if our higher ups think that that's okay to do. So we're going to try. We always had a lot of interest in this. There's like 150 of you on this presentation. So there's always a lot of interest in this. And we like to, I liked this when I first came to Mayo. I thought this was a really good structure. We've tweaked it since then. But I think it really kind of makes it easier for our staff to understand how the pieces fit together, for the patients to understand it, and for the dialysis social workers. I think it's really helpful. Okay, any other questions? We've got like a few minutes left. Anybody
Hold
got anything
on.
else?
Can you give me the referral information, please? Are they asking for the referral for the transplant?
Yes, I can give you a
Okay.
phone number. You know, most of the dialysis centers just send it in through
Yeah.
whatever their system is. But there is a fax number. You can also call our, actually, wait a minute, let me. Do you want to answer another question while I try to find that?
There's not another one
Oh.
right now, Pat. Just every few great information, great presentation. I learned so much. I'm interested in any future WebExes you offer.
Yeah, we are going to be offering some new ones. Let me talk about that for a minute. Whoever sent me that, who's asking for the referral information? When I send the email to you guys
Jennifer.
I will send you the link. We have something called CareLink, and I'll also get you the fax number to fax referrals to, and the phone number. Okay. So I will send those things too. If you guys are not in CareLink, we suggest getting that too, and I'll send you a flyer for that. That is a new automated way to send us referrals, and you can actually check on your patients that way, live up to date, where they're at with our center. The other presentations we're going to be doing, I think the next one is going to be the end of July. That will also be for one CEU from the Florida board, which is usually accepted by all state boards. It's going to be on living donation, and how to help our patients find living donors and what the process is. The one after that, I think, is going to be helping your dialysis patients get through the Mayo transplant process. And then we'll probably have one more, I think, the end of the year, on like an Ask the Team. So where you can just ask all of our team any questions that you've got.
Maybe
and
I missed it, but does Mayo transplant patients over 73 years old?
And yes, we do. We have patients in their 80s here that we've transplanted. What we don't use an age cutoff. There's no age cutoff here. It's really your condition when you walk in the door here. So are you healthy? Because we have 80-year-olds that come in that look like 50-year-olds. We have 50-year-olds that walk in that look like they're 80. So it really is on your physical condition and your comorbidities. So we do not have an age cutoff at this center at this time. Okay.
Do you do preemptive transplants,
Yes.
DDKT and LDKT?
Yes, 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 yes. This is a real, we're starting to focus more on the preemptive patients, and our docs are going to be doing a presentation, I think in August, early August. They're going to be reaching out to nephrologists and some primary care docs, I think, in the Southeast, to try to help them figure out when is the right time to send their preemptive patients to us. If you guys have doctors who would be interested in that, just shoot me an email too, and let me know that.
Our
And again,
anonymous attendee says that is on August 3rd for the preemptive webinar.
Thank you. I think I know who our anonymous attendee is.
You're a
Got
wealth
people
of
helping her,
knowledge
though.
today. I know.
Okay, does our anonymous attendee actually have the referral information?
I know,
That would be
right?
helpful.
Can you provide a list of exclusions and inclusions that we can use as a reference?
I can send you, in that email that I send you, I will send you the criteria. But what I would recommend to you is send everybody, if you're at a dialysis center, you really are supposed to be sending us everybody at this point, and then just let us kind of weed through. We have different layers of triage. So there's an initial triage that will just, anybody who's got too many comorbidities, they'll be removed from that at that initial triage state. But it doesn't hurt them to go through the process here. BMI is one for us. I think BMI is a cutoff as 40, but I can send that criteria list to you guys too. Giving me a
Okay.
lot of homework here.
Can
Good.
can New Jersey snowbirds list in Florida? Yes, they can. They do it all the time.
Yeah, we actually
Um,
have a lot of New York and New Jersey patients down there.
yes, we do. I joined in late. Is there anywhere or a website where we can get this info? Pat is going to send out the PowerPoint so you can look at it there. Also, anyone knows Medicaid for kidney ESRD patients? Pat addressed earlier for transplant, kidney transplant, we don't accept Medicaid only patients at Mayo Clinic. What is the maximum BMI for consideration for transplant?
I think it's 40. Oh, and
Right.
there's the referral line.
There you go. Our anonymous attendee sent us some numbers
Thank you, our anonymous attendee.
and the email address.
Very good.
All right.
Oh.
Okay. And the
Good to have friends
criteria
attend your
list.
webinar.
You know? Do you ever run into problems with insurance only paying for one evaluation? Do you share eval info with other transplant centers?
We do. I don't think we run into problems, and I don't do the insurance, so I don't know that that's an issue. But we do share information between the centers. So the way this works is a lot of centers have Epic, and there's something called Care Everywhere in Epic. So we can see testing that's been done at Cleveland Clinic or at MUSC and places like that. So we can, Piedmont, I think, we can see the testing and they can see ours. And we do share that information. And if we can't see it in the chart, patients can get it and get it to us. Okay. We really appreciate all of you attending this. It's really nice and it's good to hear from you guys. We like hearing from you. Next time I'll make sure that the chat's working. Okay. All right. If there's no other questions, nobody slipping anything out there?
No.
We're going to go ahead and cut this off. And if you have any problems with the CEUs or anything, reach out to us. Our emails are up here and they'll be in the presentation. So if you have any questions after this, don't feel bad. Go ahead and email us. It's not a problem. Okay. Thank you very much. And thank you, Lakaya and Jeanette.
Thank you.
Thanks.
Bye, everybody.